Thank you, David.
Thank you very much. This one, right? Yeah. Thank you very much for the invitation to speak here, and it's an incredible challenge to speak after Andrew Cook. So I'll do my best to give you a whiz through the highlights of the literature. This certainly isn't exhaustive, but I hope it will be able to pinpoint some of the major issues that we're looking at. Okay, so this is my conflict of interest. The first study I want to show you is something that everybody shows, and this is the presence of the LA thrombi in the left atrial appendage and not so much in the left atrium. And this is the study from Blackshear and Odell in 1996, where we saw that 21 out of 222 thrombi were in the left atrium, the rest being in the left atrial appendage. And so this is what everybody bases all of the studies and the work that we do on occluding the left atrial appendage. I want to point out, though, that this is non-rheumatic. And we all say non-rheumatic, but what people don't look at is this part of the study, which showed that, as I said, that there were 446 out of 3,500 rheumatics had thrombi, and that 57% were in the left atrial appendage in the rheumatics. So that means that it's not the same in the rheumatic patient as it is in the non-rheumatic patient. So therefore, beware of the rheumatic atrial fibrillation. If you're an implanter of left atrial appendage occluders, then we know that we go towards the non-rheumatics, but beware of the rheumatics, because it seems very tempting, but certainly there at least 40% of patients, 40% of the thrombi are not in the left atrial appendage in that group. Very, very briefly, the first steps into left atrial appendage occlusion were with the Plato device. This is a ball-shaped device that was made of nitinol. And then there are a number of studies that came out of this. I'm actually just going to show you one study, which was the initial study from Park, where he published in 2009 in the Journal of Invasive Cardiology. This is a single-center study with 73 patients. And as you can see, they were almost all anticoagulant ineligible patients. And so this was the first time that we actually got to see something in terms of the sizes that we're looking at, what the orifice was, what the length was, measured not in pathological form, but rather from the interventionalist perspective. And here we could get to see the sorts of sizes of devices that were being implanted. The important thing was the results that were shown at 24-month follow-up of 71 patients. There were no strokes in a CHADS-2 score population of 2.5. That means with an expected 7 strokes, there were 0 strokes, which is a very impressive result. The bugbear of this was, in fact, the procedure-related major complications. And this is the first time that we saw this, and this was something between 4% and sometimes reached up to 10% in some of the other studies. And these included sudden cardiac death that resulted from the embolization of the device into the aortic valve. There was a patient that actually the device embolized and therefore underwent urgent heart surgery, and there was a stroke. So these were the sorts of complications that were first seen, and the Plato device disappeared from the perspective, but it gave us, or from the landscape, but it gave us our first look at what we were due to expect. The major work, and this is needs major congratulations to Atritech for this major study of the PROTECT AF clinical trial. And as we all know, and we've all known and seen this study, so once again, I'm not going to spend too much time on it, but it was prospective and randomized, and it was a long-term warfarin comparison study with a 2-to-1 allocation, 2 devices to every 1 patient that was treated with anticoagulants. There were 463 patients that received a device. There were nearly 60 centers that were involved, and there was a lot of TE follow-up at 45 days, at 6 months, and 1 year. So this is the crux of the efficacy results, and this showed that in fact that the Watchman device was non-inferior, at least out to 2 years, to control, and that it was effective in reducing stroke in this population that were anticoagulant eligible if they were treated with anticoagulants for 45 days and continued on with aspirin afterwards. Here too we saw the impact in the safety results of the problems of the early complications or the procedure-related complications, and there we had nearly 10%, not quite, but nearly 10% of complications early. However, the result that was maintained in the safety in the longer term, of course, was maintained, and therefore over the longer term it came out to be much more, actually no change as opposed to that we were developing with anticoagulant complications. So this was the crux of the results that we saw in the PROTECT-AF trial, and they were able to summarize that the long-term treatment with warfarin in patients with atrial fibrillation was effective, but it has its difficulties and risks that we've already heard about today, and that the PROTECT-AF trial showed that that there was a significant reduction in hemorrhagic stroke risk, and that we know that when hemorrhage occurs, the risk of death is markedly increased, that the all-cause stroke and all-cause mortality were non-inferior with the device to warfarin, and that there was concern about the early safety events. Concluding, therefore, that it's safe and it's effective alternative to warfarin in patients with non-valvular, non-rheumatic atrial fibrillation who are eligible for warfarin therapy. If we make a very quick calculation and we look at the implant failures, which were about 9%, and the safety results, which were close to 9% also, we're getting close to 18% of patients who had some sort of incident with this procedure. And so therefore, when we look at what is our stroke risk without anticoagulation in patients, and so if we choose a CHADS 2 score of 1, which is around 2 to 3%, then we would need to be pretty convinced that we have something that's very, very solid to offer it. So if we're looking at this 18% versus this 2 to 3%, we would therefore, at this point, in any case, will not want to treat the patients who are at very low risk of stroke from atrial fibrillation. We would therefore want to choose patients who are at significantly higher risk. So what was the next step? And I think this is a crucial step, and this is a publication from Vivek Reddy in Circulation last year, and this was the Continued Access Registry. This was the group of centers that had performed, I think it was greater than 15 procedures in the PROTECT-AF, and they were allowed to continue to deploy devices. And so therefore, what we can see here is actually that they're a slightly more challenging group, and so here we can see there's almost the same number of deployed devices, and it's a slightly older group and it's a slightly higher CHADS score, but on the whole, relatively similar group of patients. And the important finding here is that if we look, and this is a little bit complex, this table, but look here at the PROTECT-AF group and look here at the Continued Access Registry group, and we can see that the procedure time reduced. We can see that the implant's success went from 90% to 95%, that the procedure or device-related safety adverse events decreased from 7.7 down to 3.7, and including reduction in pericardial effusions, and particularly the disappearance almost of stroke. If you look at what happened, and you can see that this is clearly learning curve related, that they did a very nice analysis of early patients in the PROTECT-AF as opposed to the late patients in PROTECT-AF, and this was seen also, the same reduction. So therefore, the improvement and the reduction of complications was based upon the development of experience in the procedure. And this was borne out in this study, and that was one of the crucial things that we found from this study. Here we can also see from this publication that once we reduced the complication or procedure-related complications, therefore the maintained efficacy continued, and so therefore there was no loss of that, and so that we've moved. I think this is what the Continued Access Registry allowed us to see, that if we can reduce the intraprocedural complications, we can actually bring ourselves to a procedure that is much safer with maintained efficacy, resulting in a better procedure altogether. The reason and indication for these patients undergoing left atrial appendage occlusion was predominantly bleeding risk. And if we write here bleeding risk, but we can include here prior hemorrhage, that also must be included in that bleeding risk. So we're really up to almost 90%. And this is an interesting observation in the number of lobes that were seen. So the results showed that in almost all cases the device could be deployed. That was 197 out of 204 patients underwent successful implantation, and that this is, once again, the group of implanters who have more experience, because this is the follow-on from the first study, and so therefore the number of times the device needed to be changed or changed in size was only 10%. The occlusion rate at implant was nearly 100% at 6 months maintained, and there were no leaks greater than 5 millimeters, and the closure rates remained consistent at TE evaluation from the implant through 6 months of follow-up. So that's you can see over here, and that really that there was successful and stable occlusion of the appendage with this device. What were the event rates and what were the procedural event rates? We can see in under 7 days there were still this same 1.5% of serious pericardial effusion. There were 3 device embolizations, resulting in 3% of event rates, which was a reduction from the original PARC study, which was 7%, which I didn't show you the number, but it was 7%. But if we see what else happened, there were some device-related thrombus out beyond 7 days at 2.5%, which is something that's interesting and one of the first times we're seeing that, and we'll have to look at that in a second. If we look at the implications we got from the continued access and see what happened from the EU prospective study that now I'm showing you, as opposed to the initial European registry, that's the Professor Park study that I said before, that 143 patients to 204 patients, there is a significant improvement with a reduction in the number of stroke, with also a reduction in the number of pericardial effusions. Device embolizations don't seem to have changed. It's still quite low, but nonetheless present. But we're talking once again here about event rates of 2.9%. The stroke risk, therefore, in this group of patients, if you look at what happened with this group, they ended up with a 65% reduction in stroke risk from their estimated CHADS-2 based estimation, and so therefore that was considered a successful and effective procedure in this group of patients who were not anticoagulant eligible. What antithrombotics were they receiving? They were almost all on a combination of aspirin and Plavix. At discharge, at 1 month, there was still majority of them on aspirin and Plavix, and the Plavix dropped off out to 6 months. I think the majority of people treating between 1 and 3 months with the addition of Plavix on the aspirin. So therefore, they summarized that this high-risk population that are intolerant of CHADS, intolerant of anticoagulation with a CHADS-2 of 2.6, they had a significant high risk they had a significant stroke history. They had excellent results with the success rates of close to 100% and occlusion rates close to 100%. There was a relatively low safety events, but still combination of the two of them reaching 5.4%, and that there was close to 2% stroke risk over 100 patient years, which with the expected of 5.6. So therefore, I think that their conclusion was correct, that there was improvement with this improved experience. Then just to show you there's a couple of other quick things that this is a registry from Belgium that was presented also at PCR, and this actually includes learning curve. So it's 82 patients that were treated between 2009 and 2012 in 7 centers, and shows their follow-up between 1 and 12 months. And this is, once again, a similar group of patients, except that we can see that the CHADS VASC score is relatively high here at 5, that we can see that it's majority of permanent atrial fibrillation, and that, once again, the same sorts of things, the patients who are ineligible for anticoagulants. So there were major procedural complications in this group, and this is the learning curve group of 8%, a total of 8% with a major of 3.6%. There were 2 myocardial infarctions that were from air embolism and 1 tamponade that was treated with pericardiocentesis, and there were a couple of pericardial effusions that were treated conservatively in an access site. There was no death, stroke, or embolizations. If we look, this is an interesting look into the 12-month follow-up. We can see that there was this tamponade that we mentioned before and this stroke that we mentioned before, but if we look out to 6 months, there was one non-cardiovascular death, and there was out later at 12 months, there was 1 cardiovascular death, but in terms of device-related issues, there were none, which was encouraging. And if we look at the event survival rates, we can see out to the 2-year point, we can get a 91% survival. So they were very encouraged as demonstrating in their learning curve that this was an effective and safe device. However, that increased experience certainly will make a difference and improve. The next study was the ASAP registry, which was presented at the Heart Rhythm Society, and unfortunately I didn't hear it, so I've only got these slides that I know about it. And so this is a really important study, which was probably the first important demonstration of the efficacy of the Watchman in the absence of the use of preliminary anticoagulation. And so this was patients who were anticoagulant ineligible, and they were treated with aspirin and or Plavix from the outset of the deployment. And so this was a study that was done in 150 patients in 4 European centers. Once again, we're seeing this climbing CHAD score, 2.8 at this point. And as I mentioned, the patients were followed as out to 2 years, and they were treated with clopidogrel for 6 months. There was a 95% success of deployment. Once again, the patient risk factors are the same sorts of things. These are high-risk patients with significantly high CHAD scores. The event rate, there was a 5%, 5 per 100 patient year death rate, stroke rate 2.3, ischemic stroke at 1.7, hemorrhagic stroke at 0.6, and a device thrombus at 3.5 per 100 patient years. If you look at this, this gives us an estimated stroke risk of 7.3 with a 1.7 effective stroke, which is a 77% reduction, which is quite similar to the European study, which showed if clopidogrel alone was given for the whole period, it would have been 5%. So that's an effective and useful estimation. 2 other very quick things that have come out, and that's from Bay et al., and this is the intraprocedural long-term incomplete occlusion of the appendage with the Watchman device that was published very recently. And this was 58 Watchman implants were assessed by TE for peri-device gaps. They were under the same protocol of intraprocedural 45 days and 12 months, and these gaps were present in nearly 30% at all stages. And one of the things that they found was that they seemed to persist and even become larger out to 12 months. The occurrence of new gaps occurred even if it was originally occluded. There was one stroke at 4.7 months, and there was a device thrombus at 21.6 months, both in the presence of these gaps. However, they conclude that the relevance of these gaps is unclear. The other was this from Vivek Reddy's groups, was showing looking at the similar sorts of things that was published in JACC also just recently from the Protect AF trial. And here they looked at the same Ts at 12 months. So this was the presence of gaps, and they wanted to see whether they were associated with events. And so if the gap was minor, moderate, or major, this was the hazard ratio, and the confidence intervals were quite wide, and so therefore there was no ability to decide whether these had any relevance at all. And so caution is suggested due to the low event rate. I was also asked to present some of my personal data. So this is my first 100 patients, and this is all single operator to try and demonstrate what happens with the generation of experience. And so this is a group of it's a relatively even split of males, females, 73 years old, a CHAD score of 3.2, with over 50% of the patients having had stroke in the past. All the patients underwent successful deployment. All the criteria except one were met in all cases. There was some minimal residual flow at angio, but echo in one of the deployments. These are the in-hospital and 30-day. There was one when pericardial effusion. If we look carefully at the complications, there was a LAA perforation with subsequent occlusion. The patient was drained and went home on day 6. There was one patient with a very severely impaired LV function, severe mitral incompetence, who had pulmonary edema due to a contrast load, and she settled down with diuretics and a very short period of additional ventilation. And there was one patient who bled on the aspirin and Plavix regimen at 14 days, and all medication was stopped, and he's been uncomplicated for 30 months. In the follow-up period, what we did was we looked at specifically the 30 patients that had completed 12 months of follow-up. And this group of patients had a CHADS-2 score of 3.9. So this is a very, very high-risk group, and they were followed up until December of 31, 2011, and that gave us a mean of 1.7 years per patient with a total of 50 patient years. The death was one patient at 6 months from respiratory sepsis that had nothing to do with the cardiac condition. There was one TIA at 9 months that demonstrated a clear device at TE. So there was no evidence of anything being on the device, and may not be related, but it cannot be excluded. There was no stroke. Echocardiographic follow-up showed a single patient had a leak that was less than 5 millimeters behind the lobe. Thrombus on the screw attachment of the device disc was present in 2 patients. That occurred, one at 6 months and one at 12 months. Both devices were deeply deployed, and the thrombi resolved with low molecular weight heparin. The patients were subsequently treated with dabigatran. I'm very going to finish now with some comments about the referral patterns. The next session refers to where patients come from, but because I've presented my data, and I'm going to quickly mention 70% of our referrals came from within the cardiology world, and so they did not come from other specialties. So the majority of our patients actually came from within our own cardiology department. They were patients who had existing oral anticoagulant contraindications, and they came in with a new episode of atrial fibrillation and indication subsequently for anticoagulation, and they were full referred. Or patients who had a recurrent AF admission, and we were discovered that at some point the oral anticoagulants had been stopped by a gastroenterologist or a neurologist on the outside. The other source was outpatient cardiologists who had the oral anticoagulants stopped for multiple reasons, and the patients were told, go see the cardiologist. I'm stopping your anticoagulants, go and see a cardiologist to decide, and subsequently they were referred onto us for occlusion. I think that the main aim is to raise the awareness, and therefore within your own department. So the most important thing within your own department for referrals from within is to make sure that your complication rate is very low. Because if your own colleagues are seeing that you've got high complication rates, then they are not going to be happy about referring the patients to you. You should speak at your local meetings, and you should present your results and be flexible about accepting patients. And if your waiting lists are long, then make sure that you can get these patients in earlier so that you can see them easily. And having said that, my caution is don't agree to treat patients that you're uncomfortable with just in order to encourage referrals. So with that, I'd like to thank you and wish you a great rest of the meeting.
Thanks a lot for this excellent overview. We will have the discussion at the end of the session. Thanks a lot.